Welcome, everybody. I always wait until people trickle in from the waiting room before I launch into all of my announcements and pleasantries. And I think almost everybody is in. So, good afternoon, everybody. Welcome to our 5th annual Gynecologic Cancer Webinar Series. I'm Rachel Rosen-Simpson. I'm the program manager here at the Breast Cancer Coalition, and I'm so glad that you could all join us to learn more about pelvic floor PT with Brenna Johnson, who is a doctor of physical therapy. We are grateful to the Saunders Foundation that supports coalition educational offerings like this series, because we couldn't do it by ourselves without the support of our community sponsors. Before we begin today's presentation, I always have a few housekeeping announcements to share. So, if you need closed captioning, that little CC button at the bottom of your Zoom screen can give you captions in whatever language you like. Or at least I think it's pretty comprehensive, at least. I will facilitate a question and answer session following the presentation, so please type your questions into the chat function, and I'll continue to compile those as the presentation unfolds. And then I'll share them at the end with our amazing presenter, and we will answer as many as possible before we try our best to wrap up by noon. And just a disclaimer that because our presenters don't know all of you, they cannot give any specific medical advice for your individual case during this short time we have together. So if you could try to keep your questions broad and inclusive of others, that would be much appreciated. If you want to watch the presentation again, it's being recorded and it will be added to our webinar library on the Coalition website, as well as uploaded to our YouTube channel, which is also now publicly searchable. So you can share it with anybody who you think would benefit, and that is always our hope. I will drop both the link to the webinar library as well as the link to register for these future Wednesday webinars into the chat, and also a link to Dr. Johnson's presentation if you didn't get it in that reminder email with the Zoom link and you want to follow along. There will also be a survey that pops up whenever you leave the webinar, and we do utilize that anonymous feedback when planning our future program offerings like this. So please complete the survey if you're willing and able to, and help guide us in the future on what you would like to see. All right, so today's webinar features a very special guest, Dr. Brenna Johnson. Brenna is a native of Cortland, New York, and she earned her bachelor's degree in health sciences and doctor of physical therapy from Nazareth University in 2022 and 2024, respectively. She enters the physical therapy profession with a growing passion for empowering patients to unlock their full potential. I feel like empowerment is a huge focus of today's conversation. She feels that personalized care and compassion helps to inspire patients to surpass their limits and find joy in living a healthier, more active lifestyle. While at Nazareth, Brenna was a member of the women's track and field team for 5 years, competing in sprints and jumps, which I think is amazing. I would rather not sprint unless someone's chasing me, so well done. She received All-America honors in 2021 and was the recipient of the Elite 90 Award in 2022, which I have no idea what that is, but I'm sure you deserved it. When not in the clinic, Brenna enjoys anything outdoorsy, running, hiking, kayaking, as well as finding cute dogs to pet, which, same. We're so grateful that she could make the time to be here with us today. And I know your schedule is slammed, so we appreciate it so much. So without further ado, take it away, Brenna. Thanks again.
Thank you so much. And thank you all of you for being here. This is obviously a huge passion of mine, and I'm just really excited to be able to hopefully give you a little bit of knowledge about like pelvic PT, but then also just show you the joys of getting into the pelvic realm and how passionate I am about trying to help any individuals that I can, especially individuals with like women's health concerns. It's been a very big passion of mine for quite some time. So I'm going to get my presentation up. And then let me just get this organized. So In general, today we are talking about pelvic floor physical therapy, and then more specifically, how we can address very common side effects that we see after a hysterectomy, pretty typical like pelvic concerns that we see. And then, like Rachel mentioned, I'm going to give a broad overview on like how we would treat, but primarily we are looking for, one sec, let me just make sure. There we go. Primarily what I'm doing is just giving you like broad overview, and then obviously if you have very specific concerns, we'll make sure you feel connected to if you wanted to reach out with more specific questions about receiving like a more individualized evaluation. So, this has already been pretty well covered, a little bit about me. So, movement has always been a huge part of my life. And honestly, where I feel like I really thrive is helping individuals feel this sense of community and belonging and just using movement as a catalyst to reaching your full potential. Human beings feel a little bit better once they can get up and moving, but sometimes we just need a little bit of guidance on how to do that, especially when it comes to pelvic conditions, because there's a lot of unknown and subsequent fear on like how to move and like what is kind of going on in the pelvis, especially if we have any sort of like pelvic floor dysfunction. So I specifically treat pelvic as well as orthopedic conditions, and then also running with pelvic floor dysfunction is another passion of mine. So diving into it, what we're going to do, kind of acquaint you with the pelvic floor. So individuals with female anatomy actually have 13 muscles that are considered to be the pelvic floor muscles. There's a lot more going on in the pelvis than some people realize. So I just want to acquaint you with roughly like what these muscles are, what do they do, what is pelvic floor physical therapy, and more specifically, how we do pelvic floor physical therapy at Limitless. It is a little bit different anywhere you go. So I want to just show you what it could be. And so that way you feel empowered to like advocate for yourself of like what you're looking for. Common symptoms post hysterectomy, treatments for said symptoms, and then honestly, like what it is you feel like you would need to thrive, questions and answers, all that good stuff. So, the pelvic floor, these are muscles, and I do have a pelvic model, but because I might be really small on people's screens, I'm just going to kind of explain it. Um, You've got pubic bone in the front. So if you, from belly button, felt downward to pubic bone, and then you've got tailbone in the back. Your pelvic floor is a sling of muscles that connects pubic bone to tailbone. And we essentially always describe it as like this bowl. Its job is to hold everything up and in. It's got 3 layers, as I mentioned, 13 different muscles. And on our next slide, you'll see primary functions here. Sexual function, so anything related to sexual wellness, whether that is arousal, orgasm, anything like that. Sphincteric function, which is urinary and fecal continence. So kind of like what we say closes down the holes. Support and stability, like I mentioned, it holds everything up and in. It is our active support. And then this last one, it's called sump pump. So I always use the example for individuals when we're like traveling for a long period of time, let's say, and like there's like fluid that'll start to kind of like your feet start to swell a little bit, especially if you're flying. And people will kind of do like calf raises or squats, uses muscle action to kind of get fluid out of like your feet and ankles. Your pelvic floor actually does the same thing to make sure fluid isn't like pooling in the pelvis. So it kind of pumps some of that up so that way it stays in circulation. So anytime when people are getting some feelings of like this dull, pressury, heavy sensation in like lower abdomen, um, just kind of getting the muscles to wake up a little bit can be helpful. So overall, that's our pelvic floor. I don't necessarily need people to understand the intricacies of all the different muscles, but just like what is the pelvic floor is a great first step to help kind of figure out like what is going on down there. Um, so we can always like come back to anatomy, help people understand that because I think education can be really powerful. So, hard to talk about the pelvic floor in isolation without talking about what we call the core canister. So, our pelvic floor never functions in isolation. It works with our entire core canister musculature, which is essentially if you were to kind of wrap around this like mid-torso region, you've got your abdominal muscles in the front, you've got a deep abdominal muscle that wraps all the way around, you've got your back muscles, all of that works together. And then the top of the core canister is your diaphragm, and then the bottom is your pelvic floor. We need all of this to be very strong and to function together to help with our symptoms. So pelvic PT, if you've ever Googled it and like you're like, wait, I see some like interesting breathing exercises or anything like that, it's because our diaphragm actually plays a huge role in our pelvic floor function. They actually work together in unison. Um, and what I tell all my patients, you can have the strongest pelvic floor ever and you can still experience symptoms of pelvic floor dysfunction if everything around the pelvic floor is a little bit weaker. So we need you to be very functionally strong and resilient as a human being, especially after an operation. We need all sorts of strength through that area. So your pelvic floor doesn't have to do all the work. So, what is pelvic floor physical therapy? And I use this picture, but I don't want to scare anyone that's like, wait a second, I'm not a gym person, I'm not a huge weightlifter. It doesn't necessarily have to be that. What I tell patients all the time, I do not care the weight that you lift, whether we are lifting a kettlebell or a barbell in the gym or whatever it might be. Being able to lift heavy is so important because I tell individuals all the time, like, you are picking up grand kiddos off the ground when they are probably pretty heavy. So we need to be able to train for that function. So it might look similar to this, but we have a very specific goal in mind. And all physical therapy should be super functional, but especially pelvic floor physical therapy. Um, and then especially after an operation such as a hysterectomy, um, there's going to be questions and symptoms you might bump into and fear about said symptoms. And this sort of thing can seem really, really scary. So getting to have like the guidance of a professional that can help you kind of bridge that gap of like, where am I now and where do I want to be? I have no idea how to get to where I want to be, but I know this is what I want. We just use physical activity, resistance training, whatever it might be, to kind of get you to bridge that gap and get you to where you want to be. So, pelvic floor, we call it pelvic PT 2.0. Pelvic PT 1.0 is probably what is on Google the most of, okay, I'm having pelvic floor dysfunction, and it says, all right, you're doing 3 sets of 10 Kegels, do it while you're sitting on the toilet, and try to stop your flow of urine. And there's your home exercise. You're just doing those all the time. And I am not discounting that. I think there is a time and a place for that. But like I mentioned earlier, we do not live our life in isolation. We do not live our life just seated doing Kegels, standing doing Kegels, lying down doing Kegels. We live our life more like this picture where we have a kiddo that wants to be picked up and swung around and wants to be outside playing, wants you on the ground with them, wants you back off the ground with them, jumping around, dancing, all the good stuff. And that can seem very scary when you're having pelvic floor dysfunction or just in general, if you just don't feel like you have the strength or resiliency to do that, which is where it becomes so important that you are doing functional strengthening. So even before we get into like the symptoms, I felt like it was really important to know, for all of you to know that advocating for feeling like your physical therapy experience is very functional to get you back to doing things like this picture. I also included a quote from a study from 2022 where it said women lifting weights roughly less than 30 pounds are more likely to report prolapse or heaviness symptoms than those lifting greater than 50 kilograms or 100 pounds. So the reason I incorporated this is because that is probably the top myth I bust for people about prolapse. Individuals are told like, okay, I have a prolapse. I was told to not lift anything heavy. but then you have this adorable grandkid that just wants to be picked up, and you feel restricted in doing that because you were told, you can't lift anything heavy. That's not fair to you, that's not reasonable, and that's not a quality of life. And this study alone just completely busts it. People that were lifting less felt more symptom burden. And because what's happening is, like I said, our pelvic floor is that sling. It's that sling that holds everything up and in. And if you're intentionally not lifting anything heavy and not working it out, similar to your leg muscles, you need your leg muscles to stand up from a chair. But if you're not practicing that or like working those out, they're going to get weaker over time. And that's why we have a greater symptom burden. So if you're not training your pelvic floor or getting really strong throughout that entire core canister, you're going to feel symptoms a little bit more. But I don't want you to think like I'm still very fearful. I don't want you to think that's not valid because it, unfortunately, Rachel and I were talking before this started, a lot of things with women's health is just, it's not validated in the way it deserves to be. And so a huge step that I feel like I am in a really cool position to help is validate our patients and then educate them on like, all right, here's how we're going to go about this to do it in a smart way. I don't anticipate, like, I don't need people to be lifting 100 pounds. You just have to be able to lift however much you want to be able to functionally for your best quality of life. So that's why we call it Pelvic PT 2.0. So it's a little bit more of a fitness forward approach. So, what I'm getting into today, here's probably the most common symptoms I see post hysterectomy: urinary incontinence, pelvic heaviness or prolapse, sexual dysfunction, and constipation. I'm going to go through each of these, kind of a little what it is, as well as some broad symptom or some broad treatment plans we take. So, starting with urinary incontinence, there's a few different types. I just included our most common. You've got urge incontinence and you've got stress incontinence. Urge incontinence is a sudden, uncontrollable urge to urinate. So it is like you arrive home, let's say, for example, and you're like, everyone get out of my way or else I am going to wet my pants. And I can't control this. Even if I have just gone recently, like, nope. So typically there's those like environmental cues or triggers for people arriving home, putting their key in the door, when they see the toilet, running water, standing up from a chair, like all of a sudden you stand up and you're like, oh, I need to go now. Got a couple different ways we address this. Sometimes it's that connection between your brain and bladder can get a little wonky. So that's what we call urge suppression techniques. So that helps you just feel a little bit more like, all right, I can control my urge. Potentially you're getting that urge to go super intensely or super frequently because it became a habit. So probably like example a lot of people can relate to is like as they were growing up and your parents were putting all the kids in the car and they're like, all right, everyone go pee. We don't want to stop, everyone go pee, which is fine. But then we kind of developed this routine of like, okay, every time I leave the house, even if I just peed 10 minutes ago, I'm going to go again just to be safe. And now our brain's getting a little confused because we're emptying so often that it's like, oh, we need to be signaling a lot. So we do some bladder retraining, and then potentially it could come just you feel like you can't control the urge because your pelvic floor isn't quite strong enough, and we need a little bit of strength there. We can absolutely address that. Stress incontinence. This is more of the urinary leakage due to laugh, cough, sneeze, and any other increases in intra-abdominal pressure, so that pressure in your belly. This could be lifting up that adorable little grand kiddo. It could be doing yard work. It could be getting out of bed. It could be getting off the floor. Um, and this is where it becomes super important that everything in our core canister, the core muscles, the back muscles, the hip muscles, all of that is really strong. Um, we address this a couple different ways. This could be a coordination thing. Maybe just our pelvic floor is not quite turning on at the right time. Maybe it's a strength thing. Or maybe we realize like, oh, when I'm doing some of these other effortful things, getting off the floor, getting up in bed, standing up from a chair, I'm actually holding my breath. And when we hold our breath, that actually puts a lot of pressure down on our pelvic floor. So we need to find out, why are we holding our breath? Is it just like, no, it's just my habit? Or is it because like, oh no, this is really effortful for me. Like I'm really working hard to get up out of this chair and it's like, huh, and we're up. in which case we just need you to get a little functionally stronger so that way your pelvic floor is not taking on those increased pressures. So, like we mentioned, it's a little bit more, we need a bit of an in-depth evaluation to figure out like what it is for you specifically, but just know like laugh, cough, sneeze, like having urinary leakage with that, if you were ever told like, oh, that happens with age, it doesn't need to. That can be addressed, it can be dealt with, and it can go away. Um, so we can absolutely address that through physical therapy. And this is something we see an uptick in both of these after like a hysterectomy. There's a couple reasons we see upticks in pelvic symptoms after hysterectomy. It's a pelvic surgery. It's a major lower abdominal pelvic surgery. What we know about our muscles after surgery is sometimes they're like, what the heck was that? And they get like really, really tight because they're like, we need to go full protection mode. That can actually cause these pelvic floor dysfunction symptoms. Or they're like, oh, I have no idea what just happened. I'm going hands off for a little bit. And maybe we have a little bit of weakness. That can also be addressed. And then the other thing is after hysterectomy, especially if it's been a little while, what we know is estrogen is actually very protective to our pelvic floor muscles. And if we start to lose our body's like natural supply of estrogen, then we can start to see some more pelvic floor dysfunction as like our pelvic floor muscles get a little bit weaker because they don't have that estrogen supply. That can be addressed through like topical estrogen or it can be addressed through pelvic floor PT. We end up typically recommending just like a combination of things. It's an and not or situation where the more support you can get, the better. I incorporated some bladder irritants on this slideshow as well because what we know in regards to urinary symptoms is our bladder, if it is a little bit, if the bladder lining is a little bit more irritated, it tends to leak a little bit more frequently, and then it also will give that increase in urgency. So I tell people all the time, I'm gonna just educate you on this. It doesn't necessarily mean fully cut all of it out, especially if your favorite drink is one of the, has like some component of this. It's more so something we can look at about, okay, if we're only having urinary symptoms around when we have like our Diet Coke one time a week. Is that something you're okay with? Or if not, do we want to try to decrease it? Do we want to pair it with water so that way our pelvic floor isn't at, or like our bladder isn't as irritated? Um, but alcohol, carbonation, so any sort of like seltzer, pop, something like that, artificial sweeteners, caffeine, and then nicotine, and then space foods and acidic foods as well. So sometimes this is as simple as let's just we're noticing symptoms. Here are urinary symptoms that we're noticing. Maybe we keep a diary and figure out, okay, we had really intense urges this day. What were we consuming? And can we relate it to our bladder was just irritated? I already covered this pretty in depth. Urge incontinence, we've got urge suppression techniques, addressing the pelvic floor, and then fluid intake. Most people, when they have urinary leakage, are like, oh, I'm just going to stop drinking water. The less I put in my body, the less I leak out. Similar to those other bladder irritants that I just listed, being dehydrated is also irritating to our bladder because when we're dehydrated, we have that concentrated urine that's a little bit like darker in color. Um, that'll irritate our bladder a little bit more. So that's not to say if you typically drink 20 ounces of water and I tell you I want you to be at 64, that you drink 64 the next day. Because then you and your bladder are just not going to be happy. That is way too quick of an increase, but we want to slowly increase to help dilute the urine so that way it's, even though it's a greater volume, it's less irritating to our bladder. Stress incontinence. How do we treat that? So remember that is our urinary leakage with laugh, cough, sneeze, and then or something effortful. If it's possible, we want to remove the trigger. So for some patients, if it was I was coughing all the time, but then and having a lot of leakage, but actually I started on like an inhaler or I addressed my respiratory concerns and now I'm not having leakage. Cool, great, that's perfect. Or allergies. maybe if we can get some like allergy medication so that way we're not sneezing all the time. So the goal is to remove the trigger where possible. Working on the coordination of our pelvic floor. So like I mentioned, we want our pelvic floor to activate when we have a cough or a sneeze. And sometimes what we see is that the pelvic floor actually just like pushes down and lengthens a little bit, which is what we say kind of like opens up the holes. So then obviously we're going to have some more symptoms. So we might just need to work on teaching your pelvic floor when to turn on with a cough or a sneeze. Similarly, removing those bladder irritants if we need to, and then addressing what's going on with the pelvic floor. Is it a coordination thing, a strength thing? Um, is it a pelvic floor that's a little too tight? All those things are possible and can all lead to urinary symptoms and can be addressed through pelvic PT. All right. Pelvic heaviness and prolapse. That was that second common symptom that we see post hysterectomy. Um, The definition in general is descent of one or more of either the anterior vaginal wall, the posterior vaginal wall, the apex, or rectal prolapse. So I incorporated a bunch of pictures here to the right-hand side. Um, the most common one we see after hysterectomy is a vaginal vault prolapse, which is just the top of the vagina descending downwards. So, what we need to educate patients about is sling, all pelvic floor muscles that make up that sling that hold everything up and in. If they, for some reason, are not offering the support that we need, we can see a shift in bladder, in rectum, in top of vagina. Um, and that's where you start to develop this feeling of like pelvic heaviness or pressure. This is a little bit different than like lower abdominal discomfort. This tends to be like pressure felt vaginally or rectally. Um, I included one stat here at the bottom that 50% of individuals actually have, so 50% of Paris women, so individuals that have had kiddos, actually have some amount of pelvic prolapse. However, only 3 to 8.3% actually have symptoms. So this is to say, not that, oh, if you are experiencing symptoms, you're alone. Absolutely not. It is to say, if you are diagnosed with some sort of pelvic prolapse, but it's not impacting you functionally in your day-to-day, like don't stress. You can absolutely still come to pelvic PT and start to work on a little bit more pelvic floor support, but don't feel like, oh my goodness, what is happening to me? It's a lot of individuals don't always get affected in their day to day. So this is just the overarching definition. So we're going to dive into different causes and everything. But before I dive into the causes, first and foremost, your organs are not falling out of you. That is probably the top myth I have to bust in regards to pelvic heaviness and prolapse. It is purely pelvic floor muscles. We lost some of that active support from them for whatever reason. And now we see a little bit of a shift. So, what you're feeling in that pressure is movement of anterior vaginal wall, posterior vaginal wall, or top of vagina, just shifting. Nothing is falling out. I can assure you of that much. So, similar to everything with pelvic floor, there's a lot of different answers. So, there's a lot of different things that's going on. Coordination deficits. I mentioned that entire core canister. If that core canister isn't all working together, pelvic floor is taking on way too big of a load. So we just need to help give it a little bit of support so that way it doesn't feel like it's having to do all the work. Where it says pelvic floor muscles end up in the basement. This would be a huge education piece that you would get in pelvic floor PT. We tend to use, just so we have common language, if you were to do a Kegel or a pelvic floor contraction, we call that the attic. So that's squeeze everything up and in. And then rest is what we call first floor. And then bearing down or pushing down, like you're trying to have a bowel movement, for individuals that have had a baby, like you're trying to push, that's our basement. And if obviously if we're in the basement and like pelvic floor is bearing down, pushing down, we're going to get some like pressury symptoms. So we just need to figure out like where does your pelvic floor exist in space and how do we get it to exist where we want it to? Weakness, so insufficient support around the pelvis. So pelvic floor, core canister, tension. Um, People tend to think like, oh, if the pelvic floor is tight, I should hold everything up and in. However, what that does is it actually creates limited amount of space. Because you think about it, it's that sling. If it pushes up because it's super, super tight, stuff doesn't really have the room. And all of our organs like to have room to exist. So it's going to kind of like push down, try to move out of the way. So a tight pelvic floor can absolutely cause these symptoms. And then bowel irregularities. So constipation, there's just a greater volume of stuff there if we're struggling to empty our bowels, that can actually create some of these heaviness symptoms as well. So, actually, before I move on from that, I kind of mentioned all the different reasons we might have heaviness symptoms. If it's a coordination thing, we first and foremost, if it's a big spectrum of what pelvic PT is, it is first awareness and education, learning about everything that's going on here. Then we need to coordinate our pelvic floor. You can have the strongest pelvic floor in the world, but if it's not turning on at the right time, it's not helping us out enough. Then we address strength and then endurance of the pelvic floor as well, which is just can it be active for a long period of time. Weakness, obviously, if it's pelvic floor is turning on at the right time, but it's just not as strong as we need it to be, we strengthen. Tension, if it's kind of stuck up in that attic, we first need to gain access to the full range of motion of your pelvic floor. So I tell all my patients, you need a full range of motion of that muscle similar to every other muscle in our body. For example, your bicep on your arm, if your bicep is super, super tight, your elbow is going to be stuck in this bent position. First and foremost, before we care how strong your bicep is, you want that muscle to be lengthened so that way you can fully straighten your elbow and then fully bend it. Um, so first we'd gain access to that range of motion and then we would strengthen. And then bowel irregularities. This is something where we need to address more so the trigger than address the pelvic floor. The pelvic floor might be perfect, but if you're experiencing constipation, there's not so much like that's what needs to be addressed rather than the muscles themselves. So, constipation, super common after a procedure, especially a pelvic procedure. This could be from medications. This could be from changes in the function of our pelvic floor. And this could be because we just had an operation and we're not moving around quite as much. Um, in which case, all of this can be causative of constipation. And similar to, like I mentioned earlier, a lot of stuff with pelvic is not like a one size fits all. It's going to be a combination of stuff. And that's where a pelvic floor PT can be a great advocate for you in figuring out like what it is we need to address all these different things. So for example, how we address constipation, there's a lot. There's a lot that goes into our digestive health. First, we want to make sure from a diet and like intake perspective, we want enough fiber. So that way, if stool is super, super firm, that's going to be harder to pass. Also is true, like sometimes looser stool still can be make someone feel constipated. So making sure we are addressing our fiber intake. Are we getting enough to begin with? Are we getting enough of each type, soluble versus insoluble fiber? And then water intake. That can go both ways. If you're severely dehydrated, that can make stool very firm. And also if you're overhydrated, which is not a problem I typically see. Addressing toileting position. So I'm actually going to show you on our next slide. If you haven't heard of a squatty potty yet, they're fantastic. So this is every pelvic PT's dream. Super, super helpful. Out of those pelvic floor muscles, those 13 lovely muscles, you have one of them. It starts in the front on your pubic bone, actually wraps all the way, kind of goes up one side, wraps in and behind the rectum, and comes back up to the pubic bone on the front. And almost makes like this, it like wraps right around behind rectum. When we sit with our feet flat on the floor, our knees level with our hips, pretty standard toileting position. That muscle actually creates a little bit of a kink in the rectum, and it makes stool a lot harder to pass because it kind of has to follow this like treacherous pathway. Versus squatty potty, get in, and doesn't necessarily need to be a squatty potty. Anything that elevates your knees above your hips. I have patients that use yoga blocks. If they have any like kids at home, if they have a step stool, all that good stuff. Because then we actually loosen and lengthen our pelvic floor muscles when our knees are elevated above our hips, and that can help to decrease that like tough pathway for the stool to follow, and it actually puts you in an optimal position. So, going back here, addressing toilet position, exercise. Super important for a couple reasons. A, stress management. Um, a lot of individuals hold their stress internally, including in their pelvic floor. And if those muscles are super, super tight, it is very hard to pass stool through there. So maybe we use exercise for stress management. Also, there is great research supporting the benefits of aerobic activity and improving your bowel motility. So that's where I mentioned sometimes constipation after surgeries because we're not up and moving around quite as much. So if we can just gently increase your physical activity, that can help address constipation. And then finally, if we do all these lifestyle changes, there could still be stuff going on at the pelvic floor, and we can absolutely address that as well. Whether it's a pelvic floor that's too tight and that's hard to get stuff through, or maybe our core is a little bit weaker, and when we're trying to push out a bowel movement, it's not moving because we don't have the strength there. So all of that can be addressed. Perfect. The other common symptom is changes in our sexual function. So various things we see post-hysterectomy: decreased libido or sex drive, painful insertion, or pain with deep penetration, vaginal dryness, and then fear related to other pelvic symptoms. If you're having urinary leakage, you just might not feel quite as comfortable regarding like sexual function. Um, so that's probably like the most common ones I see. Again, that's not it, but I just wanted to kind of hit like the high points. So this doesn't always seem like something people want to bring up. I totally respect it as a very intimate part of someone's life. And if you aren't feeling comfortable with it at first, that's completely understandable. But it's also something I feel very passionately about, advocating for individuals to regain physical intimacy in their life if that's one of their goals. Um, just because of all the benefits it can have. And in all honesty, I tell everyone, anyone that has female hormones, everything about sexual wellness is a little bit more complex, complicated, difficult to navigate, and there is actually a lot more that goes into it than people think. Um, and it is more than just the muscle function, but it still can be addressed in pelvic PT. We are trained in addressing a lot of these other components to it that I'm going to talk about. So we definitely want to promote sexual wellness for individuals. If you think women's health is underrepresented and understudied, women's health when it comes to sexual wellness is unfortunately receives like the lowest amount of research and respect that it deserves, but we are slowly changing that. So I took those 4 symptoms and I am gonna just briefly talk about how we address it. First and foremost is I'm actually gonna start right at number 3. I'm gonna actually kind of go backwards with this. When it comes to fear, education is so important. If you can just hear like, oh, what I'm feeling is normal. It doesn't need to be my forever. It's valid. And I feel like I have hope for addressing that. Huge wins. That is greatly helpful, and helping individuals just feel empowered. Also, if you're not feeling super comfortable and maybe this isn't something you've discussed with your partner, we can trial like, okay, how do we discuss this? What does it mean? Because if you're not really knowing what's going on in your body, how can you communicate that to someone? So I always feel like if I can educate my patients, they can educate their partner, then that improves that relationship even more. And then you can kind of navigate this with someone else. You don't feel like you're navigating alone. Next one I want to talk about is vaginal dryness. This one we typically discuss like topical estrogen, um, lubrication, that sort of thing. So that one's a little bit less. We kind of more give ideas in helping that. Addressing the muscles doesn't always address that exactly. These other two are where like pelvic PT really can help too. Obviously, it can help with like the fear and the empowerment too. But painful insertion. This is could be a couple different things. Could be a pelvic floor that's a little bit tight, because then kind of hole's gonna be closed down a little bit more. It's gonna be a little bit more sensitive, and we kind of tend to educate people about our brains are super protective. Our brains are not designed to make us feel perfect. They are designed to keep us safe and alive. And if we've had an experience that has been painful in the past, if you've experienced painful insertion, painful intercourse in the past, it's going to try to protect you. And it's going to tense up a little bit, cause your pelvic floor to tense a bit. And then that's going to create a little bit more pain. So our job is to figure out where can we kind of put our foot in the door and stop that cycle from occurring to where insertion becomes less painful. Inevitably, if something is painful, we might not wanting to be doing that all the time, so that can cause libido to drop a little bit. So if we can get it to be a little less painful, that can also help to increase libido. There are some pelvic tools too. If we find that it's purely like, all right, your pelvic floor just exists in a little bit more of a tense state, there's vaginal dilators that help the whole pelvic floor relax. There's pelvic wands that if we've got like one spot in the pelvic floor that's a little bit more sensitive, we can get with a wand. And then there's a tool called O-Nut that is for pain with deeper penetration. And honestly, it actually like prevents that like full depth penetration because sometimes top of vagina can get a little bit more sensitive. And then finally, decreased libido. This has been an area that I've really enjoyed learning more about to help patients understand. Um, so arousal is a parasympathetic activity. So what that means is we've got two sides to our brain, or like two different functions. We've got sympathetic, which is fight or flight, and then we've got parasympathetic, which is rest and digest. A lot of people will think like, okay, intercourse, got to be amped up, try to like get a little bit more into that fight or flight almost of like really trying to ramp heart rate up, all that good stuff. However, arousal is actually a parasympathetic activity. We need to feel safe, comfortable, relaxed to experience arousal. So this might be stress management. It might be down training where we're trying to bring the whole nervous system down a little bit. It might be relaxation techniques, getting ways to let your entire nervous system feel a little bit more relaxed to help with libido. So now this is essentially those are the main symptoms I see post hysterectomy, and those are kind of an overview on how we address it and all the different things pelvic PT can do. Um, and usually a huge, well, not usually, always, huge part of at least how we address physical therapy in general, where I am currently at, is anyone that has urinary leakage, one of their goals for PT is probably going to be to stop peeing their pants. Anyone that has pelvic heaviness when they pick up their grandkid probably doesn't want to experience that. But what's really important is you kind of dig in and like really figure out why, especially when it comes to pelvic symptoms. It's such an intimate part of people's lives that, yes, of course, we want to address the impairment or the symptom, but what does that mean? If that symptom is gone, what does that mean for you? What are you able to do once that is gone that maybe you were fearful of or you didn't do? Like, sweet, now I don't feel the heaviness symptoms and I am getting on the floor with my grandkids and I'm picking them up and I'm actually watching them 2 to 3 times in a week, but I was fearful of that beforehand because I felt like my body couldn't handle that. Like that's the more important part, and that's where someone's pelvic physical therapy journey, physical therapy in general, but especially pelvic, so important that we kind of tie that to the deeper meaning and the deeper why on what you're doing. Um, which brings me to our mission and vision is we create a thriving community that inspires the best health outcomes. We don't want to just stop at pelvic floor strength. Like we want it to become a whole lifestyle, an entire like lifelong thing for you. That's us specifically. And I am sure that is true everywhere else. I hope. But then I wanted to also just incorporate our names of our pelvic team. So we've got a couple different specialties here at Limitless. Um, we treat balance and vestibular. So balance, dizziness, concussion. We treat orthopedic, knee pain, ankle pain, back pain, neck, all that good stuff. And then we also treat pelvic. So if you were ever perusing our website, our website is going to be linked as well. Um, these are the names of our fantastic pelvic providers. So we've got 3 locations here in the Rochester area. We are trying to be conveniently located throughout Rochester, and then we also have a fantastic team down in Cortland, New York, where I'm actually from. So that's very exciting for the Cortland area. And then in general, our contact information. Um, if you were just calling about anything else or also for pelvic specific, this is kind of how you would contact us. And Rachel, I don't know if you want me to keep this up or if you want me to get rid of the sharing the screen.
I think we could leave it on for maybe another minute or two so that if people want to write anything down, they have the option. I
Sure.
suppose pop back up here too. Although it looks like you have a couple more slides that you wanted to address. So
Yeah. So the next slide is similar to this one. It could have just been like left up. It's just about like our mission and vision. So it's totally fine. And then it's like a do you have any questions slide. So
yeah, because we have time, but I think everybody has been so wrapped by your presentation that nobody has dropped questions in the chat yet, which
totally fine.
okay, we got one. Well, first off, I also wanted to say, I don't know, I hope that everybody here learned a whole bunch. I certainly did. And I really wanted to just tell you how much I appreciate this holistic approach where coming to physical therapy actually incorporates, we're a whole person with
Mhm.
feelings, and those feelings affect our bodies, and our bodies affect our feelings. And so, in order to address any sort of pelvic floor PT, the fact that you are looking at not only what's the shame, what's the stigma, what's getting in the way of you feeling your best,
Yeah.
but also the visioning exercise of what will you be able to accomplish? What do you hope to accomplish? And how do you hope to feel if
Yeah.
we can address all of these things? So I hope that everybody who has participated today feels um, like they don't have to suffer quietly alone through these things. And any symptoms that they may be struggling with, my hope for this series is to empower all of you and to help you to know what resources exist so that we can eliminate barriers to care and you aren't feeling like this is your lot in life that you're stuck with and you just have to suffer silently through it.
Yeah.
No, no,
Yeah.
I'm not okay with that. So, however we can support you is what we want to do. So that said, I have 2 questions now. And we've got some time, so this is really good. All right.
Perfect.
First question. How much apply? Ooh, more questions coming in. Great. How much applies to salpingoophorectomy? I hope I didn't butcher the pronunciation of that, but I apologize in advance if I did.
Um, Honestly, everything. So the only like it's still like very much a pelvic surgery. The only thing that changes in regards to the different types of removals that we get, total hysterectomy versus not, is whether we have a good estrogen supply on board still, like from like our natural support of estrogen. It doesn't change our approach at all. And it just kind of varies person to person. Some people might have a total hysterectomy, but they're not quite as symptomatic than some people that still have ovaries. So it's very much person to person, but I would say all the information still applies.
Okay. And I also wanted to address the topical estrogen. something that we talk about here a lot because there's a lot of fear for many hormone positive cancers, which many GYN cancers are fed by hormones. There's quite a growing body of evidence that topical estrogen is a safe way to get a little help, and it's localized such that it's not systemic. So that if you have a hormone positive cancer, you can talk to your doctor about whether that's an option for you. But many of the folks here have gone that route and have found a lot of relief in
Mhm.
doing so. All right. Second question. What do you do for shortened vaginal vaults after robotic hysterectomy?
Yeah, that's a great question. It's going to be a little bit different, which is, of course, like a frustrating answer that I feel like we get a lot, but depending on the symptoms. So, what we can see with a shortened vaginal vault is painful intercourse, especially with that deeper penetration. So, that's going to be addressed in how I mentioned finding ways to maybe minimize how deep the penetration goes. So, maybe that's like a pelvic tool. It can also cause other pelvic floor dysfunction, increased feelings of pelvic pressure or heaviness symptoms. What we tell all of our patients, even if we can't, let's say someone is diagnosed with a prolapse, we might not change the anatomy of it. What we care about changing is the symptom burden and what someone feels subjectively. So if we noticed we get a little bit more movement, so vaginal vault descends a little bit more, and you just have these feelings of like pressure and heaviness. We work together, and all of a sudden you're like, wait, I don't feel it. Your anatomy is still the same, or maybe it's still existing in the same place, but cool, you're doing all the things you want to be able to do. Let's continue on. Like, we're good. Um, so that's kind of, we would focus a little bit more on the symptom burden that you're experiencing from that.
Okay. I had a question because you made me laugh out loud when you were talking about increased hydration and how going from 20 ounces to immediately 64 ounces from one day to the next will make your bladder very grumpy. I don't think grumpy was the word you used, but that was what.
Yeah, it's a
So,
perfect way to describe it.
so I was curious how quickly, and maybe it depends on the context of each person, but how quickly to increase one's intake of water. Um, because most folks I think are probably not drinking enough water, and we often forget because we're all busy and
Yeah.
yeah.
Yes. That's a great question. I honestly tend to tell patients like if we take where we're at and we take where we want to go and we kind of figure out like a realistic goal. So if someone is experiencing urinary urgency or frequency already, we probably are going to go by increasing by like a quarter of a glass to half a glass per day. Just and we'll kind of figure that out. It's kind of a trial and error. Like let's try to increase by a quarter glass and see if that makes you feel like you have to go even more. But if it's someone where it's like, no, I don't have any sort of urinary symptoms, I'm not fearful of drinking water, I just don't do it. Maybe we're trying to find one other place in their day where we intentionally schedule like a new glass of water. Because I found like if you just tell someone like, hey, you're gonna drink more a glass extra per day, it might not happen. So it's like, okay, where are we not drinking water? So I tend to have patients try to do it like before they start with like a bladder irritant. Um, so if I have a patient that's like, oh yeah, it's first cup of coffee, like coffee is the very first thing I drink in the day. Like, okay, while it's brewing, can we try a glass of water there or something? So typically by half a glass to a glass per day.
So actually, if you could stop so that we could see your beautiful face a little bit bigger, that would be great. Thank you.
You're welcome.
So is it generally a good idea to before you um, before you consume any irritants to water them down, I guess literally.
Yeah, that's typically my recommendation, either right before, simultaneously, or right after. Um, just because, yes, we're introducing more volume to the bladder, but it's volume that it appreciates a little bit more or it doesn't get like as aggravated by. Um, but If someone's not, it kind of depends on the volume of the irritant too. So if someone's drinking like a huge mug of coffee, we're gonna try to get like a little bit of water in, but then like we already know there's gonna be huge volume going on in the bladder that maybe we do it after.
Okay.
But yes, it is the typical recommendation to have it before, with, or after, like immediately
And
around the irritant.
okay, sounds good. I will endeavor to drink more water before my coffee.
Love it.
All these things away. Um, Similarly, I wanted to ask about the squatty potties, because I was actually given those as a baby shower gift, which I thought was a wonderful thing.
Yeah.
And I do love them, and I would highly recommend them to other people.
Yeah.
Are all squatty potties, you said that you can also cobble together like anything that just raises your knees. Does
Mhm.
it matter if they're in front of you, on the side? Like, are all squatty potties created equal? Do you have a preference of where you put your knees?
Um, I tend to just have patients. I would recommend either feet forward or slightly wider, versus coming together. So when we kind of come together with our feet, we do close stuff down a little bit more. Um, so for example, like if you're trying, I tell patients because my main goal is that knees are above hips. That's
Mhm.
like the number one goal. However, if someone's using like their little kiddo's step stool and their feet are super, super close together and they feel like they're squeezing their inner thigh muscles to keep their feet on, our inner thigh muscles actually send overflow activation to our pelvic floor. So turning them on will actually turn your pelvic floor on. And when we're trying to have a bowel movement, we want everything to be like nice and relaxed. So it's a little bit dependent. So I typically recommend just kind of like right forward as if your feet were on the floor, but just there's something right there underneath them.
Okay, sounds good. Got one more question here. Is
Mhm.
it possible that the bladder would enlarge after a hysterectomy? Probably because maybe there's more space in there.
Mm.
Um, There's a participant who feels like they can go longer in between urination post hysterectomy. Is
Oh,
that
cool.
the thing?
Yeah. I don't know necessarily if it's like the surgery itself. So our bladder is a muscle, which means it can functionally expand and it can functionally shrink. So, like I had mentioned, if someone's like going to the bathroom all the time and they're not letting their bladder fill, then it's like the signaling gets a little wonky with the brain that it just is like, oh, we have to go sooner and sooner. We signal sooner and we get a little bit smaller. When there is more room, because it's a muscle, it can expand. And that is absolutely like huge win, especially if you felt like you were going frequently. I just kind of caution people about waiting too long. If our bladder gets a little too stretched out, then again, the signaling can get wonky. So if you're still emptying like that every 2 to 3 hours, super appropriate. That's great. And it's probably because there's a little bit more room. You're not receiving pressure from the uterus anymore on the bladder wall. Because when we kind of get pressure, similar to like with constipation, if there's a lot of stool there, it pushes everything forward. We bump into the bladder. Constipation can cause urinary urgency. So now it sounds like you just have like the ability to expand a bit more.
Okay. And then this is a perfect sort of summation question. Is there a referral required to get pelvic floor PT? Do you accept insurance? And then there are some other questions about performing internal exams to determine what muscles in the pelvic floor are contributing to symptoms. And do you prescribe equipment for sexual therapy? So there's a whole bunch of questions in there, all wrapped in one.
I love
And
it.
technically have 1 minute. Oh,
Cool.
yeah.
Oh, we're done. No, I'm kidding.
I know.
Okay.
I
Um,
control that, so I think we're good.
Perfect. New York State has something that's called limited direct access, which means depending on the insurance, we have 30 days or 10 visits together without a referral, depending on your insurance. So, off the top of my head, I do know Medicare, we need a referral. And managed Medicaid, we need a referral before we start treating. Other than that, we can start treating, and as long as we get that referral. So, what would happen is you let us know, like, who the referral would be coming from. And then we just reach out to your provider and ask for the referral, or you can call them and say, like, hey, I would like to go to PT. It's usually not a fault. So we have like about a month to work together. As for performing internal exams, yes. Any provider that has their license can do a lot of what we can do, but they can't do internal exams. So that's where being a pelvic specific specialist, we can absolutely do internal exams if someone's comfortable with that and they're like, tell me what on earth is going on. We can absolutely do that. It's very comprehensive. It's not at all like a gynecological exam or gynecologic exam. It's a one finger assessment where we can tell you how the muscles are at rest, their level of movement, their strength, their endurance. Like we can get a lot of information, but it's not a requirement. So I never want that to be like a reason someone does or does not come to PT. Um, Prescribing equipment. We give recommendations and then we have specific companies where we love what they stand for. We love their mission and vision. We love their products that we get discount codes from them, but we don't necessarily write prescriptions for them.
So just recommendations.
And then if you have like an HSA, that's kind of like a reach out to your insurance and see if they consider it to be a medical equipment because I have written a bunch of letters of medical necessity for them.
That sounds great. All right. Well, I think we're technically 2 minutes over time, but I think that was so wonderful. Thank you,
Yeah.
Brenna, for sharing some time with us. And thanks to all of you who were able to join us this afternoon. Next week, we're going to be talking about management strategies for lymphedema and scar tissue as we continue our weekly Wednesday webinars at lunchtime from noon to 1 throughout September and then through October. So hope to see you all then. Ta-ta for now. Thanks again, Brenna.
Thank you so much.
Bye, everybody.